Hi, everybody. Hope you're all keeping well. Um, Sorry for that little pause. It was telling me it wasn't recording. So just had to check all the equipment. So hope you guys are well. And yeah, we've got an interesting X-ray that actually came to me, and I was hoping we could have a look at it. So this is the X-ray, and we're just going to talk about it for a second, and then we're going to go through what we actually find. So this was an 11-year-old male who presented with left hip pain. He had just been bumped, not very hard, but he had been bumped. And he started to experience quite severe pain on the left hip. He couldn't walk properly. He couldn't bear weight on the leg. He couldn't abduct the leg properly. In fact, any attempted movement caused quite a bit of it really made him feel terrible, let's put it that way. And he had quite significant soft tissue swelling as well and things like that. Now, if you were to just look at this X-ray normally, actually it wouldn't look that bad. But when you have a closer look at it, and especially at the left hip, you start to notice something is wrong. So with all our pediatric patients, we've always got to look at the epiphysis, epiphysis, physis, and metaphysis. And that's the same on the left hip where we're having a problem. So with hip x-rays, of course, you've got ossification points and that to worry about. But whenever you've got left hip pain, of course, you're going to start at the acetabulum. You're going to have a look at if there's any problems over there. You're going to have a look maybe at the iliac ridge over there. You're going to have a look at the pubic rami. And when you come here towards this epiphysis, it may not be initially that obvious, but what you start to notice is that the epiphysis here is not in the exact same position as the epiphysis here. In fact, if you look at the epiphysis here, you can see it kind of makes a nice round, continuous line, and here it just seems to dip a little bit. Here we'll get to what's happening at the top here a little bit, but you can see they just kind of don't match up exactly. And in fact, you can see it much better on this X-ray that was done. So you can see there, it just seems to have moved a bit. It just seems to have slipped a bit down, probably. And this is something that we call a slipped capital femoral epiphysis, or slipped upper femoral epiphysis, or SCFE is what we used to call it before. Now it's called SCFE, slipped capital femoral epiphysis. Excuse me, my coffee hasn't kicked in for today, or my Red Bull, which I normally have with my coffee, allows me to see colors quite nicely. So this is not a common injury, but it's one that you have to suspect in a particular group of patients, which are younger patients, male patients, those involved in minimal trauma. And the thing is, it's your presenting symptoms that should actually get you sort of thinking about it. So let's look at our presenting symptoms for these types of patients. So it's pain in the hip or groin area. Now, that's quite important because very often I have seen these patients coming with just groin pain. In fact, you may think it's a groin strain because it's associated with minimal trauma. You may think, okay, you know what, it's nothing too serious. Maybe this patient just fell down. Maybe he's just pulled a tendon or a ligament or something like that. And then it often radiates to the thigh or the knee. And this is quite common as well. They have a limping or altered gait. In fact, they have difficulty walking from what I've noticed in most cases. In fact, most of the patients who I've seen often come in with a crutch or somebody helping them to walk, or even a wheelchair, because it can be extremely painful. Those who have maybe a higher threshold will come in with this limping or altered gait. They tend to have a very limited range of motion, especially internal rotation of the hip. So if you try and internally rotate that hip, in other words, bring one knee towards the other, you'll find that they scream in pain. It's extremely, extremely tender for them. And outward turning of the leg, again, outward rotation, abduction is extremely painful as well. So these are some of the things that they present with. Now, what I found often catches people out is the type of trauma that occurs. So it's often just a bump, a minor fall. Sometimes it's on the soccer field, the cricket field, the rugby field, but it doesn't look like it should be causing any major problems. But this is one of those cases where you've got to remember that the age group that's affected is the issue. So it typically affects adolescents, peak incidence, but not only in those between 10 to 16 years. So it can occur younger. It can occur up till about 18 years, even 21, if there's delayed fusion of the bones. Gender prevalence, it is more common in males than females. This does not mean it exclusively occurs in males, I have seen it in one or two female patients, but it is much less common in females. This has to do with the angle of the hip as well. It's much more difficult for that epiphysis to actually slip, but it does occur, that's for sure. So obesity, high incidence in overweight or obese children, but not exclusively. I've seen it in quite a lot of thinner kids as well. Ethnicity, it varies by region, but there's no specific ethnic predisposition. We've seen it across all races and ethnicities. Underlying conditions you can find, but generally, what I've noticed with the underlying conditions in the emergency department, we're not too concerned with that. The reason being that once these patients are passed on to the orthopedic surgeons, and if they start to notice that this patient has maybe a recurrence or, there's bilaterals or there's a bit of that going on, then we can see that there's something going on. My apologies. I'd forgotten my phone is connected to the computer and always getting phone calls for that. So it also took me a bit by surprise. So like I was saying, the underlying endocrine disorders are normally, investigated afterwards. You wouldn't normally worry about this unless there's very obvious signs of hypothyroidism, or the patient is on growth hormone treatment if it forms part of your workup. If they are telling you about it, renal osteodystrophy is not something you normally pick up in an emergency department. Okay. And then your management in the emergency room is quite simple, actually. The main thing is recognition. As I've always told you guys previously, it's our job in the emergency department is to recognize when there's danger and pass the patient on to the right people. So this is our initial assessment. We have to evaluate the hip properly, internally, externally rotate, abduct, and of course, if there's severe pain on internal rotation, don't go further than that. You can sort of say, okay, this is what's going on. So imaging, x-rays of the pelvis, especially the AP and the frog leg lateral to confirm the diagnosis. Now, a lot of the time, if you suspect it clinically initially, great, do it. For most of us, an AP would actually be sufficient, and I'll show you why just now. So immediately you take the patient off weight bearing. So you put them on a bed, you put them on a wheelchair, but it's better to have them on a bed. Pain management, depending on the age. I have had a child that we've put on opiates because it was extremely painful. And then we've had children who responded to paracetamol, sometimes Valoron drops, things like that. So it really depends on the amount of pain that the child is in. And it also depends on the amount of slippage that's taken place. And also depends on how aggressive you've been with your examination. So you could have done damage as well. Of course, we consult with orthopedics. Unfortunately, most of these patients require surgical intervention. It's very difficult to stabilize it due to immobilization. It's really very difficult. So most of these kids do need to go into theater, post-operative care. Of course, if you're working in the Department of Orthopedics, you'd worry about avascular necrosis and chondrolysis should it occur. Now, these are some of the things that we can look at. So let's just look at the grading first. So grade 1, of course, is a minor slip. Grade 2, you can see, is less than 50% of the epiphysis that's moved posteriorly and inferiorly. And grade 3 is more than 50% of the epiphysis that's moved posteriorly or inferiorly. So that's how you figure it out. Now, this is the easiest one for us to use in the emergency department. That's Tretowen's sign. So what happens is that if you draw a line across a line drawn tangentially to the superior femoral neck, Klein's line, it intersects a small portion of the lateral part of the capital epiphysis, and in posterior displacement of the epiphysis, the line doesn't intersect. So in posterior displacement, it's very difficult, or you won't see it. Now, in an anterior displacement, which is very uncommon, I must be honest, posterior and inferior displacements are the most common, but it may occasionally happen that you don't pick this up. But I'll be honest with you, if you do this test 99% of the time, you are going to pick these up. And in fact, if the patient has to come back, you've actually got something to stand on to say, okay, listen, you know what, we did what was necessary, and this is what we found. So let's just have a look. So let's take this one here. So let's look at the right hip and let's draw a line. Ooh, that's a bad one. Let me take that. Let's try another one. Sorry. Let me try and get this a bit better. Sorry about that. So let's rather than me doing it, let the computer do it. It'd be much better. So let's draw a line on this so you can see. Okay, that's much better than mine. So you can see that when you lay the line down, it easily passes through that capital epiphysis. And when we do it on this side, you can see it doesn't really transect it. It kind of just goes along the edge of it. Let's make this a bit thinner and let's do it on this side. So you can see it with the thinner one, it will probably show up a bit better. So you can see it just kind of touches the posterior edge, or let's say the superior edge, just over there, but it doesn't actually transect it as it does on the right-hand side. So that's the easiest way to tell the difference. And I must be honest, I saved my skin quite a few times when looking at these x-rays. All right, so I hope you guys enjoyed that. It was just something that we see once in a while. It was an interesting one that came through. And yeah, I hope you guys learned from that. And hopefully we'll have another one soon. Okay, keep well. Bye.